We're going to go ahead and get started. My name's Alan Weil. I'm Editor-in-Chief of Health Affairs. We're very happy to welcome you to our event this morning on housing and health. This event is part of ongoing work we are conducting with the Robert Wood Johnson Foundation around the concept of a culture of health. You'll hear from David Adler momentarily, who can probably describe that better than I can, but it's a lot about building an environment in which healthy options are the easy options and understanding that health arises from multiple circumstances. We've published a large number of articles on the quite broad range of topics that would be subsumed under culture of health, but we seem to have hit a real chord when it comes to the relationship between housing and health, and so it's nice to be able to spend a little focused time on it this morning. Just to introduce the subject briefly, it's sort of intuitive and obvious that there's a relationship between housing and health. You can't really be healthy if you don't have stable, safe, secure housing. But it turns out that once you get past the intuitive and obvious, it quickly becomes quite complex. First of all, the relationships are actually fairly complex. There's stability, there's safety, there's neighborhood, there's access to services. And again, with support from the Robert Wood Johnson Foundation, we have published 4 policy briefs in this area that have received great pickup, and they really will take you deeper into the complexity of that relationship. A second complex element is that fixing housing is really, really hard and really, really expensive. I hesitate to say whether it's more or less complex in healthcare, but it's certainly in the same vein or in the same ballpark in terms of complexity. This is concerns about affordable, safe housing have existed for centuries, and it's not as if we're sort of have something in the healthcare sector that we can just drop in the housing sector and solve the problem. And in part because it's so expensive and complex, one of the challenges that often arises in healthcare when you're trying to deal with social context is you have to target your resources. The health sector cannot afford, even though it has a whole lot of money, to solve the housing problem for everyone who intersects with the healthcare sector. And so as we think about the relationship between the two, there's a great deal of complexity around what's the relative responsibility of the health sector, the housing sector, where should the resources be targeted. And then we get to the most fun type of complexity, which is where health affairs plays, which is in the complexity of policy. There are very separate policy spheres when it comes to health and housing. They're very separate funding streams. There are different levels of government that are engaged in these types of policy. And so if you're trying to solve one or both of them simultaneously, you have to not just think about them separately, but you have to think about how different they are and how complex it is to bring them together. And so in that context, it's our pleasure to put on this event this morning. As we like to do at Health Affairs, we will have our first panel focused more on the empirical side. What have we learned? What does the research show about the relationship between these two topics? We have 4 people who will be presenting work that's been published in the journal on the topic. And then we'll move to a policy-oriented discussion, looking at the steps various sectors and organizations are taking, working at the intersection of housing and health, what they're doing, what challenges they're confronting, how they're trying to overcome those, and again, what the policy issues are that underlie and that need to be moved forward to address the challenges. So we're looking forward to a full and rich morning. And with that, it's my pleasure to introduce David Adler, who I've known for a good long time. He's a senior program officer, theme operations lead at the Robert Wood Johnson Foundation, formerly director of communications for the Food Trust in Philadelphia. He's taught adult literacy. He's worked in a pre-K program in Bilbao, Spain. It's great to read bios of people you've known for a long time. You get little pearls. So please join me in welcoming David Adler.
Good morning. It's really great to be here. I want to thank Alan and the whole team at Health Affairs for putting together such a robust and exciting event. As Alan said, my name is David Adler, and I am a Senior Program Officer at the Robert Wood Johnson Foundation, and Theme Operations Lead is Foundation Speak for Deputy Director of our Healthy Communities team. And housing is an issue that has become really important for the work that we're doing, looking at how where people live affects health. As I think most people in the room are probably aware, RWJF has a broad vision of building a culture of health. That means a place where everyone has a fair and just opportunity to live a healthy life. And I think at this point, many people would acknowledge that much of what affects our health happens outside of healthcare settings. And while that doesn't make health insurance or quality care any less important, it does mean that if we're interested in improving health broadly or building a culture of health, we need to look at where people live. And as Alan said, I think on a very basic level, that's intuitive and frankly somewhat uncontroversial. If you think about it, your home determines where your kids go to school, how long it takes to get to work, and frankly, how much money you have to pay for other things that affect your health. If someone is making a trade-off between housing costs and food costs, it stands to reason that eating well may give way to keeping a roof over your head. And that's likely going to have health implications. Similarly, toxins like lead or mold in a home are going to have very direct effects on health. So not only does where you live have an enormous effect on how healthy you are, we can also see how the relationship between where someone lives can reinforce health inequities. But I think we're here to go beyond some of the intuitive aspects of this. The foundation, as I think we have a reputation for, is committed to evidence. And so we're really interested in rigorously studying the connections between people's homes and their health. And that's why Health Affairs has been a great partner to help advance the science about important topics related to a culture of health. The research featured today adds to what we know about the connections between where people live and their health, and as such gives us a stronger foundation to build upon as we look for solutions. What's also really important about today, and why I'm so excited about today's conversation, is that Health Affairs is able to bring together researchers and practitioners. As much as we all love research, and we do love it, what happens in communities to change conditions for people living there is really going to determine what happens in terms of our progress to build a culture of health. And I think that connection between understanding the complexities of the issue and marrying it to action and what's happening in people's lives and what people's lived experience brings to the conversation is where I think the really good work is going to happen. So with that, I'm going to turn it over to our very exciting panels and thank Health Affairs and look forward to today's conversation. Thank you.
Thank you, David. So if I can have our first panelists come up. As they're coming to the front, I'll just tell you a little snippet about them. And as I say, they're going to be presenting research that they've published in Health Affairs. You're going to be hearing from Robin Clarke, professor in the departments of Family Medicine and Community Health and Quantitative Health Sciences at the University of Massachusetts Medical School. Dan Treglia, postdoctoral fellow at the University of Pennsylvania School of Social Policy and Practice, formerly the Deputy Director of Research at New York City Department of Homeless Services. Erica Eliason, Social Policy and Policy Analysis PhD student at Columbia University's Population Research Center. And Kacie Dragan, PhD candidate in Health Policy at Harvard University. They're each going to have 7 minutes to tell you a little bit about what they've found in their work, drawing heavily from what they've published in Health Affairs, but we've given them a license to go a few steps beyond that. So let me begin by turning it to Robin.
Thanks, Alan. So our study focused on infants that were born during a period of homelessness, either before entering shelter, sometime in the year before entering shelter, or in the year after entering shelter. And this is all based in Massachusetts. So just a quick review of the methods. This was a case control study. We used administrative data, Medicaid claims, and data for applications for emergency shelter. In Massachusetts, this is all managed by one agency, so we think we captured the majority of families who were homeless during this period. We chose over 5,000 infants who were born during this period and matched them with a group of similar infants who were born in the same month, who had similar characteristics in terms of where they lived, race and ethnicity, and a few other characteristics, and compared them, just followed them over a period of up to 6 years, looking particularly at diagnoses and healthcare use during this period. So this is a very hard slide to see. Let's see. Oh, okay, this is a better. This just takes several different common healthcare conditions and compares the two groups in the first year of life. So there are a lot of things that are very common for infants to have to deal with. Upper respiratory problems, fever, things like that often bring kids to the emergency department. But there's also some chronic conditions like developmental disorders and asthma. We followed these over a period of 6 years, and most of these conditions remain significantly higher in the homeless group than in the comparison group for 2 to 3 years in all cases, and in some cases for the entire 6-year period. So, for example, asthma was still significantly different between the two groups at age 6, which is about as far as we're able to follow them. Also, patterns of healthcare use, emergency department use remain significantly higher over the entire 6-year period, and costs remain significantly higher during this period. So there are a lot of conclusions you can draw from this, but certainly I think we've shown that homelessness really has an impact very early on, and there is a real difference between infants who experience a homeless episode or housing instability around that, and others who are very poor, who were well below poverty level, but didn't have that housing instability to deal with. Some of these conditions may last for quite a while. Asthma, for example, can be a lifetime condition. We also know from other research that children who experience homelessness are much more likely to be exposed to adverse childhood experiences like abuse, neglect, other kinds of experiences that can have lasting effects. Now, the interesting thing about this group is that many of these infants were actually born before they entered shelter. So there are significant implications for screening in the healthcare system. These mothers, or other studies show that they spend more time visiting the emergency department. They have a lot of contact with the healthcare system, and so there is a lot of opportunity to screen. But our instruments that we use are really pretty blunt. Most of the screening tools that are used in the healthcare system now are simply ask a question, something like, are you currently having housing problems? What our data suggests is that a birth can actually be a trigger for homelessness. It can create a crisis either in the relationship, or it can simply cause a landlord to say, we now have too many people in this apartment, and you have to move out. So over half, or about half of all infants born in the country are covered by Medicaid. So it's a huge group to think about screening. It's a really daunting task to think about really carefully screening that group. In some sense, it's easier to have a smaller group that you can target, like maybe chronically homeless individuals. Yet it's clearly a place that we're failing to identify people. The other point I would make here is that prevention is really key. We now know that there are a number of things that you can do that might help families not become homeless. Things like help with rent before someone is evicted, legal support to help people avoid eviction. Evidence from other studies shows that eviction is particularly devastating for families because of all of the legal ramifications and loss of property and a lot of things like that. So this is not a problem that we think healthcare alone can solve. The healthcare community, healthcare providers can certainly do a better job of screening and recognition, but housing and prevention is really a key, I think, to addressing the problem that we found. So thanks. We're happy to take questions.
Good morning, everyone. My name is Dan Treglia. I'll be talking a little bit about some work that we did in New York, looking at the timing of, and a little bit about the reasons for hospital visits, not during shelter stays, but in the periods before and after. And I'm putting this list up. These are all the kind of the co-authors on this paper, in part to acknowledge everyone, but also to show the extent of the collaboration here. This was a project initiated by the Kelly Doran and New York City Center for Innovation through Data Intelligence as a kind of research government partnership to better understand and these kind of overlapping needs and break down a lot of these silos. You have two emergency room physicians here for NYU, you have a couple of peer researchers, and you have people in government, and this list doesn't even include kind of the government data providers who are not just providing data, but they want something from it, and rightfully so. And so they're now kind of taking this and putting it kind of into place and thinking about interventions, and that's gratifying to see. But let's go into kind of what we found in the study first. So it's no secret that people who are homeless have much higher health risks, much higher health needs than people that are not homeless, right? Generally, people that are homeless have double the mortality risk of people that are not homeless, of the general population. And there has been kind of documentation of an institutional circuit, people going kind of between shelters and hospitals and jails and prisons, psychiatric facilities, things like that. What we're just starting to see now, thanks to some work by Robin and some others, is some looking at hospital use, healthcare use in the periods immediately preceding and following shelter use. Now, part of what we're seeing kind of in a lot of this research is not just the elevated health needs and challenges, but also hospitals as kind of a source of general social services that people come in to a hospital, not just because of a healthcare need, but because of maybe some other needs. And they see this as a place where they can get some services. Also, hospitalization could be a proximal cause for homelessness. Someone comes in, they're hospitalized, then maybe they're hospitalized for an extended period of time, they lose their income, they lose their housing, and they might have no place to turn to except the shelter system. And so we wanted to do a better job of understanding the exact timing between when they're discharged from a hospital and when they show up in the shelter system. And then on the backside, when they leave the shelter system, when are they using hospitals again? And for what? So that's what we did. We looked in New York City. We took data from the New York City Department of Homeless Services, which represents more than 90% of the shelter beds. And importantly, in New York, as is generally the case in much of the Mid-Atlantic and the Northeast, most of the people that are homeless are in the shelter system, unlike in a place like LA or San Francisco, which is where a lot of the headlines have been focused on recently, where large portions of the homeless populations there are unsheltered. So we took that data and then we matched it to healthcare data from the New York State Department of Health. They have an all-payer healthcare claims database or hospital claims database, and that's what we matched to. So we had some relatively robust data sets here, and we kind of divided it into two distinct cohorts. We looked at the pre-shelter hospital use for about 100,000 people who kind of came into shelter for the very first time between 2009 and 15, and then we took people who left shelter for their very first time between 2008 and 2015, and then looked at their hospital use after that fact. So we had about a year to play with on either side. So the first thing that I'll present to you is some of the rates that we saw. So about 40% of first-time shelter users visited the hospital in the year before and the year after shelter use. Just about everyone who used the hospital had an emergency department visit, and about a third of them also had an inpatient hospitalization. And we found some, but not as much variation as we might have expected in that use based on demographic and other household characteristics. This graph here shows the timing. Okay, the middle are the periods of shelter entry and shelter exit, and what you see are a kind of a gradual in the pre-shelter period, a gradual increase from about a year to 6 months, very little, then a gradual increase from about 6 months to about 2 weeks, and then you see a vast acceleration, right, especially in the last 4 to 5 days. And that's true for EDs. It's even more clustered for inpatient hospitalizations, kind of maybe it's doing a little bit more to suggest that kind of proximal cause. And then part of what's interesting here is that we see the exact same thing on the other side, that we're seeing a symmetrical graph here showing that we see a gradual decrease in the periods after shelter exit until about a year out. So what are we concluding from that? Two things. One, not only is there an institutional circuit for people that kind of come in and out of shelter, but people that are using shelter for the very first time, people that are, at least according to these records, newly homeless, are turning to other systems either for other needs or because they're having serious healthcare concerns. Second, hospital use is prevalent not just before shelter, but after shelter as well. And that suggests, among other things, that we need to do a better job of hospital-based homelessness prevention, and we need to develop some better screening tools, as Robin alluded to. We need to think more about how hospitals are discharging people. Right, we're seeing quite a few discharges to homelessness that we need to be aware of, and also we need to think more about post-shelter aftercare. And this is one case in particular. Certainly in the post-shelter period, but even in the pre-shelter period, where CTI, or critical time intervention, that is a relatively light touch tool, could play an incredibly valuable role. And with that, we'll turn it over and look forward to questions after this.
Hello, my name is Erica Eliason, and I'm a PhD candidate at the Columbia University School of Social Work. Today I'm presenting on the impact of Medicaid expansion in California on housing evictions. I'd like to thank my co-authors, Heidi Allen, Naomi Zodi, and Tal Gross, as well as the Russell Sage Foundation who funded this work. So first, why this is important. Being poor in America comes with tough choices as families face competing demands for limited resources. The cost of filling a prescription or having an unexpected healthcare encounter may compromise the ability of low-income families to make rent or pay housing-related bills. 1 in 8 poor renting families in the United States faced rents they could not afford as of 2013, and similar numbers reported that they may soon be evicted. Almost 40% of Americans reported difficulty meeting their basic needs in 2017, including paying for housing. The majority of poor renting families in the United States now allocate more than half of their income to housing. As rents continue to rise and wages among working-class Americans stagnate, millions of families face the risk of housing eviction. Evictions are a terrible outcome for individuals and families with long-lasting consequences that can include putting people in a riskier housing market, increasing the likelihood of homelessness, and leading to worse health outcomes. Multiple studies have shown that increased access to Medicaid is associated with improved financial security, including reducing medical debt, reducing poverty, and reducing payday loan lending. Based on this literature, we hypothesized that Medicaid expansions under the Affordable Care Act could reduce evictions by freeing up financial resources for spending on non-healthcare needs, such as housing. With the financial protections afforded when accessing healthcare with Medicaid, resources can go towards housing costs that otherwise couldn't in tight financial situations. Savings from medical out-of-pocket spending could instead be used to pay housing-related bills. In addition, it is also possible that improved access to healthcare that leads to better physical and mental health could improve job ties and increase household income, thereby improving housing security, although there is less evidence for this pathway. So for this study, we focused on an early 2011 to 2012 expansion of Medicaid in California under the ACA, using data from a commercial database of evictions that landlords use to screen potential tenants. We compared county eviction outcomes before and after expansion in the years 2008 to 2013, using counties that did not expand Medicaid during this time as controls. Prior to Medicaid expansion, California counties had slightly higher rates of eviction than comparison counties. But following Medicaid expansion, we see a change in sign. If you look at the graph, the darker lines are the California counties and the slightly lighter lines are the comparison counties. So the expansions happened by 2012, that line there. So if you see prior to the Medicaid expansion, California counties had slightly higher rates and they were trending together. And then afterwards, there's a separation with California counties experiencing lower rates of eviction than the comparison counties. So we found that Medicaid expansion was associated with 25 fewer evictions per month in each county compared to a pre-expansion average of 225 evictions per month. This translates to 22 fewer evictions per 1,000 new Medicaid enrollees per year in California. When looking at counties with higher shares of uninsured residents before expansion, who would be more affected by this policy, Medicaid expansion was associated with even greater reductions, with 52 fewer evictions per month in each county. The degree to which Medicaid was associated with declines in evictions is consistent with what is known about the financial impacts of Medicaid expansion on financial security. Studies have found an 11 to 16% reduction in adverse financial outcomes associated with Medicaid expansion, as well as a $100 reduction in annual out-of-pocket medical spending per Medicaid recipient, which can be enough to improve the ability of low-income families to pay bills in a situation of tight resources. So all this matters because of the multitude of consequences associated with evictions and the fact that housing has become increasingly unaffordable. The link between housing stability and Medicaid suggests that costs for healthcare and housing may be coming into direct competition for families already on the brink. In addition, sick individuals face greater healthcare costs and may then be at heightened risk for housing insecurity when medical bills come into competition with housing bills, leaving them at greater risk of potential eviction. Because the relationship between Medicaid expansion and eviction suggests that individuals must decide between paying housing and healthcare bills, further research should explore the relationship between health and health spending on evictions. Some states are using Medicaid to pay for housing, an approach that could further improve both housing stability and health for Medicaid recipients. Our research suggests the receipt of Medicaid itself can be a vehicle for improving housing stability among low-income populations. Thank you.
Good morning. My name is Kacie Dragan, and I'm here to speak about gentrification and the health of low-income children. This work was completed when I was at the NYU Wagner Graduate School of Public Service in the Robert Wood Johnson Foundation-funded Policies for Action Research Hub. And now I'm a doctoral candidate at Harvard, but the NYU Policies for Action Hub, led by Sherry Gleed and with lots of other faculty involved, is still up to tons of interesting work in this space, looking at the impact of non-health sector policies on the health of low-income New Yorkers. And so if this sort of work interests you, I definitely encourage you to continue to check out what they're up to. So gentrification and health, sort of how did we get here? How did we get interested in this topic? So as others have mentioned, there's a lot of evidence that there's a link between a child's residential environment and neighborhood environment and their well-being. And so this plays out not only, for decades, studies have shown that not only are children more likely to have poor health when they're in a low-income neighborhood as a child, but even into adulthood, those effects tend to persist. So this is obviously an important issue and an important determinant of health, but some of the mechanisms and how it plays out are less clear. And so we saw gentrification as a really interesting case study, a natural experiment to think about some of these issues. And there's basically two streams of thought with how gentrification may influence children's health. So on the one hand, some people theorize that it could actually be really harmful to children. So it could increase cost of living. There may be increases in rent, or it may threaten culture and break up social ties. But on the other hand, there's actually sort of a theory that it may help children in some ways. So as these neighborhoods gentrify and undergo change, that the increase in affluence may actually bring resources to the area that weren't there before. So things like parks and grocery stores, increased safety, and maybe economic opportunities like jobs. And so we sort of wanted to say, in a period of rapid gentrification in New York City, what was the net effect on children's health, sort of taking the good and the bad together? And so how did we do this? We basically had a cohort of about 70,000 low-income children who are enrolled in Medicaid in New York City. So we took a group born, these 70,000 kids were born between 2006 and 2008, and we followed them until they were ages 9 to 11 in 2017. And because we used Medicaid data, we not only were able to track their health outcomes, but we could also follow their addresses over time as well. And so this was a great data set for answering this question. Obviously, a big part of this story is understanding how we define gentrification, and we do go into that more in the paper. I think the main message today is that you can see here that at baseline, sort of the top half of this table, these neighborhoods, the rapidly gentrifying neighborhoods and the persistently low-income neighborhoods actually were quite similar. They had about $50,000 in mean income, and about 19% of adults had a college degree. But for the 82 neighborhoods that we defined as rapidly gentrifying, by 2015, they had seen a $15,000 increase in mean income and a 16 percentage point increase, which is nearly a doubling of the share of college-educated adults. So these gentrifying neighborhoods truly did see a transformation in economic and social transformation. And so what did this mean for the health of the children? So this is sort of our main graphic from the study, and we looked at several diagnoses, so overweight and obesity, anxiety and depression, asthma, ADHD, and some metrics of utilization. And if you look at this and you sort of say, I don't see much happening, that is part of the story. So we kind of overall don't see a lot happening with these kids living in gentrifying neighborhoods. By and large, they looked quite similar by the ages of 9 to 11. They looked quite similar to the kids in the persistently low-income neighborhoods that didn't gentrify. But there was one exception. And that exception was anxiety and depression. And so we saw that by the time these kids were 9 to 11, if they'd grown up in an area that gentrified during their childhood, they had a 22% higher prevalence of anxiety and depression. And we thought this was pretty interesting, so we dug into it a little bit further. And we found that this increase was really driven by just two groups. And that was kids whose families lived in market rate housing, who didn't receive any rental subsidies or rental assistance, and the kids whose families ended up having to move out of the neighborhood as it gentrified. And so this sort of told us that maybe while overall there may not be much happening to these kids when their neighborhood gentrifies, there may be these very specific pathways by which vulnerable children are impacted. And so that's sort of my first takeaway here, is that gentrification may not be perhaps as dramatic as commentators and people think, but that doesn't mean that there aren't specific pathways by which vulnerable children are still impacted. And so one of the ways that we saw in this study was through anxiety and depression, specifically among families that didn't necessarily have protection for rent and for the rent increases, so those in market rate housing. The other sort of main takeaway that we feel like is important from this is that poverty is really the problem. So whether you're a child who lives in an area that gentrified or not, you still face a lot of risks to your health. And so we see that through the fact that we saw really high obesity and asthma rates among these kids, regardless of the type of neighborhood they lived in. And then in another study we did, which I've cited at the bottom here, that looked at displacement, we see that these kids, about 50% of them across all types of neighborhoods, ended up moving at least once in this period. So there's a lot of residential instability and a lot of risks to their health. And so I think the last takeaway, as sort of policymakers and advocates think about this topic, which is a very hot topic right now, and there's a lot of discussion about gentrification, is that the context really matters. So New York City is a fairly renter-friendly city, especially for low-income families. There's a lot of opportunities for rental subsidies and sort of support in that way. And that's not true in every city that's undergoing gentrification. So as policymakers and others think about this issue and sort of the health of children and which children may be particularly vulnerable, the context is also very important, which I think we took away from this study in New York City. So thank you so much.
Great. So I'm going to ask a couple of questions, and then you all can join in with a few questions as we have time. I'm going to direct the first at Robin and Dan, but please, all of you should feel free on both of these questions if you have something to add. I'm really struck, Robin and Dan, in both of your papers, there's this critical role of timing. When things happen, when we measure them, when we respond, how long the effects last. And clearly, if you prevent something, then timing sort of doesn't matter because there's nothing, once you've prevented it, there's no sequelae. But for both of you, I guess what I'd like you to reflect on is, in instances where we can't prevent, what do we know about the best timing for interventions? And I realize that's a really broad question, but I get to ask them. So take a stab at an answer, if you don't mind.
Sure. Can you hear me? Okay.
Not on. Can we?
I'll just.
There we go. We got it.
Okay, great.
You're up.
So, yeah, timing is critical, and this is, when you're thinking about screening, these are usually families. My study was focused on families that are really having a lot of contact with the healthcare system. So there are a lot of opportunities to screen, and I think as I talk to providers about this, one of the questions I ask is, so how often should we screen? Should we ask people every time we see them how their housing is going? Do they feel they're in unstable housing? And it feels a little burdensome to them to do that, or to administer a screening instrument every time someone comes to visit. On the other hand, this is a very fluid condition. So you can ask somebody, 1 week even, how are they living in stable housing? Are they concerned about it? They may not be, and then the next week it may be a very big problem for them. So that's a challenge for the healthcare system. And I'll just throw another question out there, sort of thinking about the timing, is that many of the interventions you see in the healthcare system are justified in terms of return on investment. But it's a real challenge when you think about the lasting impact of homelessness on infants and young children. It's a lot harder for a single healthcare provider to think we can recoup those costs, because many of those costs occur very far in the future. And so that's a critical issue too, but I'll let Dan make sure.
So we, for a very good reason, talk a lot about prevention being kind of the holy grail of a lot of this work. How can we prevent someone from becoming homeless? How can we prevent someone from coming into shelter? And those two things are not, as we all know, always the same. But it is a very good point that kind of prevention tools are limited, screening tools are limited, and even when they're accurate, sometimes you get people when they are just a little bit too late. And one of the advances in homelessness in the last certainly in the last 15 years or so, is kind of this prevention-focused model that has multiple tiers of prevention. That right, primary prevention is get someone before they show up to the shelter system, but then there is secondary prevention, which kind of I think of as rapid rehousing. And so maybe you're not getting someone before they come in. Maybe you can't prevent the eviction. You can't give someone enough income. Before they come in New York, it would be 30th Street or the Path Center. But you can kind of create a path because so much of homelessness is fluid, is transitional. And for many people, you don't have to stay off a kind of homelessness is not permanent, right? 80% of homelessness is transitional, give or take. And that's relatively robust across household types. So getting someone through kind of that immediate crisis is important, regardless of whether or not it's kind of before they show up to shelter or even after.
Great. Let me turn to a question again. I'll focus this more to Erica and Kaycee, but anyone should jump in. Both of these are really interesting studies, and here I'm struck by the consistent theme of buffers, of families in financial strain, and what is it that prevents them from tipping into a crisis, whether it's the financial protection of Medicaid, and in the gentrification paper, I'm particularly struck by the role of subsidized housing. So again, I guess it's a broad question, but I wonder if you could reflect on how we make sure that those kinds of buffers are in place, given the dynamic nature of family experience and of communities. What's your sense of what the most effective buffers are to prevent these families from experiencing negative consequences due to financial or neighborhood shocks? Any thoughts on that?
I can start. So as far as the buffer for healthcare costs, the first, I guess, obvious policy implication would be that I think 13 or 14 states still haven't expanded their Medicaid programs. So that would be a clear one that could improve financial consequences as far as healthcare encounters. I think that my work really highlights that even small financial improvements can have large consequences for improving housing stability among low-income populations, and that Medicaid dollars could be used to improve housing, and that would go a long way to improve health and the housing stability.
So as you sort of rightly pointed out, we definitely walked away from this study feeling that subsidized housing and affordable housing is an important part of the story with gentrification, that gentrification and change and economic and social change in neighborhoods doesn't have to be a bad thing as long as the people who live there are in some ways protected. I think an interesting thing that I didn't address in the presentation but is important to think about with this is also the quality aspect of housing. a lot of subsidized housing isn't necessarily high quality housing, and that there's some of the things that were spoken about earlier, like lead poisoning and risk of various risks of living in poor quality housing also exist. So it's sort of a balance between making sure that housing is affordable for people to remain in these neighborhoods as they gentrify, but at the same time making sure that that housing, while subsidized, is still high quality and is still a livable environment for people, because you can't just keep them in place but keep them in bad housing. That's not a solution either.
Yeah, I wonder if that feeds back also into the homelessness experience of there are different things that can happen when you become financially vulnerable here, everything from having to move to losing housing, and so there's this whole continuum of responses. Let me see if we have some questions here in the audience. We have microphones and we are recording, so I'd ask that you wait for a microphone. Don't be shy. This is not the place to be shy. If you really don't, I'll keep going, but here we go, in the back here.
Hi, I'm Kendra from the American Association of Service Coordinators. We've heard some great research about children and families, but I'm wondering, is there research out there or research on interventions for the growing population of people aged 50 to 64 who often have really unique needs, or the elderly who are homeless?
Sure.
Yeah.
So one place that I can, so the answer is yes, and this project included all adults. So it included people that were adults in families with children, but it also included single adults, the mean age of which is, I think if I remember correctly, in the early 50s. And one thing that we saw one thing I mentioned is that there was little variation across demographic characteristics in terms of rates. But one thing that we did notice was that inpatient hospitalization got higher as people aged. And we have been putting a lot of thought into the aging adult homeless population, which we just put out a recent study about this in January. We predict that 65 and older group nearly tripling between 2017 and 2030. And part of what we saw in that, and we can chat afterwards to kind of talk about, to direct you to that actual study, but part of what we saw was a wide variation in needs, in that, that's reflective of the conversation we're having more broadly. That for many people, their homelessness might self-resolve, or they might need a relatively light touch that comes with a light housing subsidy. But there are people that are certainly in the aging community that are going to need additional supports. Even when we think of things like permanent supportive housing, that's going to require additional components to facilitate things like aging in place. So it's something that we're kind of starting to shed some light on. And something that we're starting to see some localities in the federal government doing something about, with expanding to Section 202 housing, but certainly someplace we need to spend quite a bit more time.
I'll just add to that is there really are some distinctly different healthcare profiles for older single adults and families. And really, I think require different kinds of solutions, different kinds of interventions. So that's a good point you're making there.
Here, and then we got two more here. Glad to see a little conversation getting started.
Carl Polzer, a longtime health policy analyst. So, from working volunteering in homeless shelters, I observed that a large percentage have cognitive issues or mental health issues. And I'm also involved in mental health advocacy. And I was wondering, what can the medical system do when somebody comes into the hospital with a mental health crisis? They're basically stabilized, and then the hospital has a large incentive to put them out. And they may be given many medications, but there's not enough time to really observe the effects of the medications. So I see in Virginia, anyhow, there's a chasm between stabilizing somebody in a hospital and then putting them out in the community. What can the medical system do to tie that up?
Good question. Any takers?
Well, I will say that there are, to my knowledge, a number of different models for trying to make the care better coordinated and to help people make connections in the community. So most of these interventions that I'm aware of are pretty intensive in the initial phase and can phase down. The other area where there's some growing evidence is supported housing. So for people who have significant mental health issues, severe mental illness, and substance use disorders often, supported housing or housing first models have been pretty effective there, but they're not available everywhere. I don't know if you want to.
Okay, right here in the aisle, and then.
Hi, Shelley Wiseman from the O'Neill Institute for National and Global Health Law at Georgetown Law. This is a question for Dan, but maybe others can chime in. I mean, I think this research that you guys did and what you found is really significant. And I'm wondering, was there kind of a prevalence of certain conditions that people presented to the ED for? Was it chronic health conditions or things that just flared up? Was it a combination? Was it mental health or substance use disorder? And what are some models that you're seeing out there that might start to address this? I mean, certainly we have things like medical legal partnerships. There in New York, of course, there are a lot of district projects and Medicaid innovation projects, but are we seeing anything that could start to really address what you guys found in your research?
Sure. So we did look. We didn't look at it at the reasons for those visits in those diagnoses as closely as we looked at the timing, but that was kind of a secondary part of our analysis, and we found what I think was more heterogeneity than I at least expected. So among adults in households without children, either they were coming in by themselves or they were coming in with another adult, the most common diagnoses, these were the principal diagnoses, were behavioral health based, right? So substance use, mental health conditions of various sorts. But still, generally, those were fewer than half of the principal diagnoses, right? Which means there's a lot more variation out there. And second, and this speaks to Robin's research particularly, for adults and families with children, the most common diagnoses were related to pregnancy and maternity. So among other things, that speaks to there are commonalities across the needs of the interventions to address both of them, for sure. But it certainly tells us that even within a population, a one-size-fits-all approach isn't going to work, and there are promising models out there. And certainly when we look at families with kids where the adults are in their 20s, compared to childless adults or adults presenting without children who are in their 50s, we need to think about them very, very differently.
Yeah, I'll just add to that. In some other work we've done looking at emergency department use by homeless individuals, we found the same sort of thing, that behavioral health diagnoses are the most common. But beyond that, there are a lot of the garden variety diagnoses that you see in any population. So it's a combination of people presenting for behavioral health disorders, but also getting a lot of their what you would call primary care through emergency departments. So it's kind of a mix.
Right here in the front.
Hi there. Thank you all for being here. Good morning. I'm Breitling with the Population Health Alliance. I'm struck by and curious about your policy recommendations. So you may want to jump in here, Alan, too. Most everything that was referenced was state and local level, which in my experience tends to be, we'll see something happen in New York City that can't possibly happen in Tulsa, for example. So what I'm curious about are national recommendations for policy on this issue, and particularly around healthcare sector and the industry. And I'm also mostly curious about as we're kind of having struggles to make even incremental change, maybe more big picture, structural, like huge shifts in maybe conversations as you've gone through this research? It's like, has anything struck you like this would be a huge difference? I heard referenced several times poverty being the underlying issue. So I'd like your thoughts on that. Thank you.
Federal policy, big ideas,
I can
transformative policy.
Yeah, sort of. I mean, my team, talked a little bit about this when we were doing our research. That what stuck out to us is that poverty is the problem. Like I said, that no matter what's sort of happening in your neighborhood, the neighborhood matters, but poverty matters more. Like, you as a family living in poverty is just full of challenges. So I think at the federal level, there is a lot that can be done. I don't think I'm in a position to recommend specific policies, but I think, anti-poverty policy in general, and sort of making progress toward making it easier for families, especially families with kids, to have enough resources to sort of survive and also thrive, is definitely an important part of the story in terms of gentrification, but also just in so many of these other sort of circumstances that the panelists have spoken about.
I'll definitely echo the anti-poverty measures because I think really the relationship between Medicaid expansion and evictions is through the financial protections. Just to your point about would this be true at the national level, we actually did look at that with a different data set, and we did find that there were associations between Medicaid expansion at the national level and a reduction in housing evictions. It was a slightly lower number because California has a higher rate of evictions, so it was just coming from a higher starting place, but we did find robust results. And one of the just obvious takeaways still is expand your Medicaid programs.
I think, speaking kind of the first piece of that, I think we more generally need to kind of reimagine how we conduct, public administration in a way that kind of removes the incentives for a lot of the silos that we have, right? When a lot of the conversations following our recent report on aging homelessness, where we did see some, at least the potential, these were kind of relatively back of the envelope calculations, but the potential for some cost savings here and there. But the question that always gets us is kind of, whose pocket is it coming out of, and who's saving the money, and that's tripping us up every time. And right, those silos of this person saving money but this one isn't, is a place where we're going to keep running into problems here, and in every other conversation that we're going to have. Right, we need to reimagine and rethink about kind of the social safety net and things that are kind of so part of this, so integral, because poverty, as has been pointed out, right, is the culprit here. So, all right, things like rethinking unemployment insurance and disability insurance that offers broader protections, because the way unemployment insurance has been structured doesn't fit kind of our current labor market. So we need to kind of go back to the drawing board and some fundamental tools that address some of the policy issues that have come up here.
I certainly agree with everything that's been said, but also I'd like to add that I think the challenge goes beyond poverty. If you look at wages that people are able to earn, particularly minimum wages, there is no state in the country where someone earning a minimum wage can afford a two-bedroom apartment without being significantly rent stressed. If, for example, in my state, someone working in the healthcare system, a medical assistant, earning the average wage would have to pay 44% of their income to rent a one-bedroom apartment, and over 50% of their income to rent a two-bedroom apartment. So wages also come into play even when people don't fall below the poverty line.
So I just want to piggyback on that really quickly, because it brings up a fantastic point. So one of the other projects that I've been involved with is something out of the United Way called the ALICE project. And ALICE stands for Asset Limited, Income Constrained, and Employed. And what we do is create on a county level, right, here's what it takes to live for a few different household compositions. And what it finds essentially is that there's another 25 to 30% of the population that are not in poverty but can't afford to make ends meet. And part of why I love being involved in both of these pieces is that you can see the continuum from being, kind of above that amount, that kind of above that Alice threshold, to then sliding into it, and then how quickly you can get from kind of being above poverty to being homeless quite quickly.
Well, I was going to say it was a great note to end on, although that last sentence maybe not so much so. But this was a really good conversation. I think it's a reminder really of where David started us out today, which is that this is a very complex intersection here. There's a lot that we need to know that goes beyond the sort of basics of the relationship between housing and health. I'll just say, even with all of the contributions of this work, our questioners drew into the conversation additional questions that we can't answer. But whether it's defining the problem, understanding it, figuring out how to intervene, or what the policy levers are, there's still a great deal of work to be done. Let's thank our first panelists for introducing the subject very effectively. And we're going to move directly into our next panel. And as we do the transition, I'll let you know who will be coming to the stage. You're going to hear from Bob Cowell, City Manager of Roanoke, Virginia, a role he's had since 2017. Redonda Miller, President of the Johns Hopkins Hospital, an academic medical center of 1,100 beds. I like this in her bio, arrived at Johns Hopkins as a medical student and is now the president of the institution. Greg Ford, Resident Service Coordinator at Dominion Place, a Beacon Communities apartment building in Richmond, Virginia. And Clarke Gocker, Director of Policy and Strategy at Push Buffalo, which is a grassroots anti-poverty jobs and housing justice organization. What I've asked our second panelist to do is to spend a little bit of time just sort of talking about what they're doing in their environment. It's quite a range of activities because we have panelists who are in very different roles. Ask them to spend about 5 minutes just describing their context, and then I'm going to come back and ask some cross-cutting questions, just as I did with the first panel, and then we'll open it up to all of you. But let me begin by welcoming and introducing Bob Cowell.
Thank you, and good morning. Almost afternoon, I guess. I'm going to give a little bit of context as to where Roanoke is, for those of you that don't, and just sort of set that stage before I launch into some of the items that we're doing. So Roanoke is a city of about 100,000 folks in southwest Virginia, in the Blue Ridge Mountains of Virginia. Maybe for us, most importantly, is we are a city that did not come into existence until after the Civil War, so actually grew up as a result of the industrial boom that occurred during Restoration. It eventually, though, became really kind of abandoned in a lot of ways. As the industry left, downtown really became abandoned, and that has been an effort in the last 30 years or so to turn that around. And we now have a really focus as a regional hub for economic, cultural, recreation, and we have a vibrant downtown. And a lot of that is built on health and wellness. And biomed research. The Virginia Tech School of Medicine is located there, as is a biomedical research institute also. It is also, though, a city of deep poverty in some areas, and this is a legacy of racism and that industrial disinvestment. There are literally within view of our major healthcare providers hospital, there are 2 medically underserved areas, and each of those have up to a 14-year disparity in life expectancy in those areas, and deep pockets of poverty. Interestingly, one of those neighborhoods is predominantly African American, and one of those is predominantly poor white population, and for very different reasons they find themselves, those neighborhoods, in those situations. As a city, we have approached the response to those challenges really in kind of 2 ways. At one scale, we continue to push and advance kind of a regional change. My predecessor deemed it moving from trains. We were a manufacturer of locomotives, from trains to brains. Most of our research activities that are going on in the community center around actually brain injuries and those types of things. So that's at one level where we're trying to advance the larger regional economy for a long-term success and gain. At the other level is really what we refer to as kind of strength from within, and that's trying to improve the lives of and the conditions of individuals, families, and neighborhoods. And so those are the two areas that we're working at in those scales. And one of the primary ways that we do that is we aggregate our federal funding that we receive as an entitlement community, and we concentrate those for a number of years in a single neighborhood. And then we use that to actually leverage partnerships with our healthcare providers as well as our nonprofits and try to gain some additional benefits associated with that. I'll say that when that started as a result of, or for the purposes of efficiency, and it only has within the last couple of years turned into a focus oriented around the social determinants of health outcomes. And that has kind of changed the game for us as well. And so it of course started and continues to focus on some of the traditional things like providing safe, affordable housing. So that deals with things like lead abatement as well as rehabilitation and new housing. But it has in physical infrastructure changes, and those are still critical components of what we do in those areas. But increasingly, it has turned its attention more to a focus on accessing health care. So those same neighborhoods now have health clinics that are both free and other low-cost health clinics operating in different areas, including inside our rescue mission or our homeless shelter, as well as one that's about to open in one of our elementary schools. It has also started an increase in focusing on access to healthy food, and we can talk about more of that when we get into the discussion, and also access to opportunity. So we've started investing heavily in neighborhood libraries in these neighborhoods. That's where we concentrate our early childhood learning programs, and in terms of getting children in third grade reading level proficiencies. And increasingly, it's also where we're focusing some of our job training efforts in these neighborhoods as well, ranging from participation of groups like Goodwill up to some of our more formal federal policies and so on. There is a long way to go in those areas. If anybody were to go and look at Roanoke, you would see that other than Richmond, we are still the most racially segregated community in Virginia. If you go and look at county health rankings, you'll see that, yes, indeed, we have moved, which is a great thing for us, but you'll see that we're still quite low on those rankings. And though the flip side of it is, if you look at things like third grade reading proficiency, we have hit marks and exceeded marks that we had set for ourselves, and we have received a number of different recognitions and accolades for some of that work that has been done. So we see progress that is occurring in those areas, both on just the improvement of the quality of life for individuals living in those neighborhoods, but then also you see that movement in those areas where it really matters in terms of health outcomes. And of course, some of those are very long term, so in some ways we'll see how that plays out as time goes on. So I'm going to be happy to talk more as we go into questions. So thank you.
Good morning, everyone. My name is Redonda Miller. I'm the president of the Johns Hopkins Hospital, just an hour up the road in Baltimore, Maryland. And it's a privilege to be here today to tell you a little bit about the work that we're excited about. For those of you who may not know much about our hospital, we are a 1,000-bed hospital in the heart of Baltimore City. We employ about 11,000 employees and very much consider ourselves an anchor institution. You may know Johns Hopkins Hospital from the news about innovative work in bringing cures to the bedside and our discovery mission and providing that kind of cutting-edge care. But I'd like to think and tell you today about harnessing that spirit of innovation and applying it to the social determinants of health. As I mentioned, we are in Baltimore City. Our founder, Mr. Johns Hopkins, and Johns was his first name with an S, he gave the hospital, when he founded it, the Board of Trustees, two charges. One, to be the innovator you know, but also to take care of East Baltimore and be the community hospital for East Baltimore. So in that vein, of our 11,000 employees, 6,000 of them hail right from Baltimore. And I'm talking about just our hospital. The Johns Hopkins Medicine Enterprise at large, together with our university, also in Baltimore City, employ 40,000 in Baltimore. We We focused a lot of our efforts to this date on job opportunities and hiring and some of those social determinants. But when you look around Baltimore City, I think our story very much echoes Roanoke in the sense that we suffered a bit of an economic decline. Some of our manufacturing, Bethlehem Steel, closed up. Jobs became scarce. And so you saw, even in the environs around our hospital, the poverty level rise. If you look at Baltimore at large, the average income is $42,000. But here in our local neighborhoods, the average income for a family is $14,000. And 60% live below the poverty line. If you look on any given night, we have 2,500 citizens who are homeless with no place to go. We all know, and this is where the intersection of homelessness and healthcare really hits home for me. If you look at that population of patients, they have a huge chronic medical condition burden, 6 times that of our other patients at the hospital, whether it's heart failure or hypertension or diabetes. If you look at mental health, their prevalence of mental health is 25%, and their prevalence of substance use disorder, alcohol, drugs, is 1/3. So we have a real, in my opinion, healthcare crisis here. We decided, and the project I want to tell you about today, we decided to partner with the City of Baltimore and Healthcare for the Homeless on a project to provide permanent, sustainable housing for patients and families who are experiencing homelessness. This was not my idea, but it was brought to us. And I want to talk a little bit about partnership. The city hospital presidents, we had started getting together for dinner to talk about how we can make a bigger impact in Baltimore. Each of us were doing things in isolation, but we felt, gosh, if we could partner our resources, couldn't we really make a larger impact? The idea of permanent sustainable housing was brought to us by Terry Hickey, who is the director of the Office of Homelessness at the city, and Kevin Lindemood, the CEO of a nonprofit called Healthcare for the Homeless, 2 visionaries and important civic leaders in my mind. And they came to us with this idea that under an 1115 Medicaid waiver, couldn't we work together to provide housing? And they had identified 200 slots across the city, apartments, townhouses, that they were willing to renovate. But the catch is, you can't just give someone a house without the wraparound supportive services. You have to, and I thank the gentleman who asked the question earlier, what is healthcare doing rather than just discharging people and washing our hands? You have to think about how do you treat their chronic medical conditions? How do you provide life skills? How do you help them pay a bill? How do you provide transportation to medical appointments, to the grocery store? Well, we had experts. The city had the expertise in housing. Healthcare for the Homeless had the expertise in wraparound services. And we had the patient population. So we decided we would target 200 Medicaid eligible patients who had chronic medical conditions and were high inpatient or ED utilizers. Provide them with the housing, permanent. Not you have a year to get back on your feet and we take it back. No, this is permanent housing. And we would provide all the necessary wraparound services and bring those services to them. And so we started this work and we're just in the beginnings of it. We're about 116 in. And I'm sure we're going to talk more about it in a few minutes. So thank you.
Good morning. I'm Greg Ford with Beacon Communities. We are an affordable housing firm where residents pay 30% of their income. Yet, despite this, we were experiencing evictions. So why would a person paying 30% of their income still get evicted? Well, evictions relatively focus on non-payment of rent, unauthorized occupants, and various behaviors. So we started to take a deep dive into what contributes, what are some of the variables of these issues that leads to the evictions. So we found that hiring a resident service coordinator who's social work trained or psychology based and placing them on the ground to work with residents to identify the issues and the needs on the ground to have more of a grassroots effort. And then we developed wellness programs where we established a computer lab, a nursing station, a fitness center, a salon, to try to provide services within the community. And what we learned is that certain variables exist. So you may have a resident who come to you because he has a $250 cable bill. His rent is $200, his cable bill is $250. And you start to look at why is this? Well, you begin to realize that he is going to adult movies and this is what he's spending his money on. So you can lecture him about that, or you can look at alternatives. And one of the alternatives was, hey, not that I'm an expert on this, but hey, there's a membership you can buy for $30 that will send you tapes, and as you watch the tape, you turn it back in. So we was able to help him to have sustainable income so that he's not spending his money on cable bills. Then we decided to partner with our local university, Virginia Commonwealth University. So what we do is we have an interdisciplinary approach. So every week we have an 8-hour clinic from 11 disciplines, from social work, nursing, pharmacy, gerontology, occupation therapy. So students are being trained while meeting the needs of the residents. So we also gain data from that. In 2012, we had 128 people go to the emergency room, and only 5 of those visits were deemed emergencies. So we started to provide services to help them to identify some of those chronic diseases and needs within the community to avoid that. We also learned that we learned that the average resident had 5 chronic diseases and was on 12 medications. Not only on 12 medications, but sharing medications and receiving advice from other residents. So we provide a lot of health education for the residents. One thing that's also helpful is we do a homeless diversion program where if you had any experience in homelessness, we're starting to tackle some of those underlying factors. So our computer lab is going to be utilized to help you bridge those family relationships, to repair those relationships. We're also going to put you in a position where you can volunteer so that you're not taking in homeless people and jeopardizing your housing. So we put you in a position where you can volunteer and help the homeless community. We're also going to begin to address some of the psychological components of being homelessness as well. We so one of the projects we did was partner with a school of gerontology, and we established a memoir project. So we're helping residents to write their life story, to find value in their life, and to set goals based on those life experiences. While the students are learning about aging, the students are taking courses around psychology of aging. So they're learning hands-on. We're also doing projects with our family communities as well, where we have primarily single mom and kids. So we're addressing those things. So we have one project called the Urban Promise, where it's a 9-month job training program, which gives them a $15-hour job at the end of that. But we're providing support mechanisms in place because keeping them engaged in 9 months of training means addressing the everyday life issues that's going to come about as well. And we're finding unique ways to bring families to the table. How do you begin to address their issues, their health needs as well? So having a resident service coordinator on the ground gives you insight on what's going on within the community and identifying those variables. Thank you.
All right, good morning, everybody. Just want to thank Health Affairs and the Robert Wood Johnson Foundation for the invitation. It's a privilege to be here this morning. So my name is Clarke Gocker. I'm the Director of Policy and Strategy at Push Buffalo. Push is a 15-year-old community-based, member-based organization operating out of the west side of Buffalo, New York. To start, we hold tight as an organization to a couple core values. So first, those closest to the problem are closest to the solution. So when we set out to do our work, which I'll get into in a minute, we turn to longtime residents and community members to kind of source a lot of those bright ideas and to understand how conditions in the community are affecting people's quality of life. A second tenet is community control of resources and really having seats at decision-making tables to create conditions where the community can be self-determined and direct resources to meet their needs. Our work hits at the intersection of affordable housing and anti-displacement work, climate and environmental justice and energy democracy, and the new economy, which involves developing new innovative business models that really put people and their needs at the center of the enterprise. Through our work, which centers community organizing and includes affordable housing development and the operation of several social enterprise businesses in the green economy, we seek to achieve a just transition. And that's a really critical concept for us as an organization and really for the movement that we're a part of, and that includes the housing justice and climate justice movements in this country. It's a just transition from a consumer-based dig, dump, burn economy that concentrates wealth and power in the 1%. And we seek a transition to a regenerative economy that puts people and planet first, that values care, cooperation, and deep democracy, and is powered at the end of the day by renewable energy and dignified human labor. We attempt to address social determinants of health with a focus on housing, energy, environmental quality, and jobs, really trying to get at the root causes of those issues. Early on in the life of the organization, we understood those connections through conversations and just deep relationship work with community members. Our organization was founded by two community organizers who just set out hitting the streets, going door to door back in 2005, 2006, to have conversations with residents. And in those conversations, they learned about existing conditions in the neighborhood. So on the west side of Buffalo, we have a high prevalence of renter occupancy. Renters outnumber homeowners about 3 to 1. Buffalo, including the west side, has the oldest housing stock in the country. Most of our housing was built before 1939, and leaves a lot of legacy environmental contaminants kind of in its wake. There's a high prevalence of absentee ownership. When the organization was founded, there was a lot of vacant land and vacant structures in the neighborhood, and a lot of the rental housing was owned by suburban landlords or out-of-state, out-of-country landlords. Energy, in those conversations, we learned that a lot of our future members were sometimes paying as much in utility bills as they would in rent. So $400, $500 a month at the time for gas and electric service. As renters, most utility services are held in the renter's name, and so they're responsible for those payments. We also found that a lot of our future members were HEAP recipients, so the Home Energy Assistance Program, which is the social safety net program administered by the federal government and states, and we found that that really served as a pass-through to our investor-owned utilities. Kind of moved those subsidies through low-income community members' pockets into the pockets of those utility companies. So, just to kind of close, we responded to those conditions through organizing. So in 2009, we were part of a statewide coalition that won a $112 million allocation of cap and trade auction proceeds in New York that was then devoted to energy efficiency retrofits. We launched a program called Push Green, which I can maybe describe during the discussion, that sought to come into communities in ways that try to change the kind of the rules of the game, the way contractors were operating in neighborhoods to deliver vital services by positioning ourselves as an intermediary between energy efficiency contractors, state bureaucracies, and everyday folks in need of energy efficiency and healthy home services. Thanks.
There's a tremendous wealth of knowledge here. I'm going to ask one question of each of you and then try to get some themes and bring in the audience. There's a lot I want to try to accomplish in the next little bit. But let me just focus in on a few elements. Bob, one of the aspects of the approach in Roanoke is this concept of collective impact. I wonder if you could just talk a little bit about that and how you use that as a motivation.
Sure. And the community had used for a number of different reasons this model of collective impact, which we really brought together all of these different parties, including our anchor institutions, local government, as well as certainly our nonprofits, and really redefining their roles based upon the issue that we were trying to overcome or the challenge we were facing. And what's been interesting for me, I've only been in the community, as you said, for a little over 2 years. What's been interesting is that model has allowed us to adapt based on the challenge and on the situation in front of us. So we've been using it, obviously, to address social determinants and within our neighborhoods and with those individuals and families. But here recently, about 6 months ago, that exact same model was used to address our response to opioid use in the community. And all of the same folks were at the table, but all the chairs were rearranged. And so it really has worked extraordinarily well that in some instances, local government may be the lead. In other instances, it may be our anchor institution, and sometimes it may be United Way. It really just depends. And that model and framework, along with a couple of backbone organizations, have really allowed us to kind of address each of these issues as they arise within our community.
Redonda, there's the local politics of housing and placement of people in need of housing, of making targeted investments in a subset of a group where the need is so large, and being a large, well-resourced institution. Those are complex under the best of circumstances. I just wonder if you could talk a little bit about how you've navigated the issues of where do you make the investments, and whom do you make the investments?
So that's a great question. We might argue about the well-funded, but I'm just teasing. So
all relative.
It's all relative. So how do you make those decisions about where to invest? And when I made my opening remarks, I'm not for sure I was very clear. Under this waiver, the federal government provides a certain amount of funding, and then the state has to come up with the matching dollars. The state in Maryland asked Baltimore City to take that role. Baltimore City is financially challenged, as you can imagine, and that's where the hospital stepped in. We're providing a lot of the funding, the $2 million in the initial project to get the supportive services launched. So that's our role. So how do we make that targeted decision? You know, we turn to some of our past experience, meaning we had dabbled in, I would say it's more than dabbled, social determinants and looking at job creation. For instance, one of the programs we're very proud of is our hiring of returning citizens who had been in prison, usually for nonviolent crimes, but were returning out of prison and could not even get an application or an interview for a job because you checked that box. We partnered once again with a nonprofit who helped get the citizen job ready and would call us and we would hire them. 4 years of employment, we have a 85% retention rate. So we knew that we could make a difference with targeting partnerships. We also knew from a pilot of this waiver, the initial around 40 residents whom we provided housing, that we could make an impact with healthcare costs. We saw that ED visits dropped by 56%, and we saw that the cost of healthcare for the patients and society at large fell by 33%. So it was clearly going to make a difference. And honestly, some of the research done here resonates with me when I think about, Dan, your work and looking at utilization pre and post shelter. How do you take that beyond just a shelter and make an impact? So that's how we decided. We felt that by pooling our resources as the city hospital presidents, it would be a bigger source of funding. And then that from literature and our own experience, that this was an area to make an impact.
Great, thank you. Greg, you describe a very intensive relationship with people who have very substantial needs. I wonder if you could talk a little bit about the people side of this. Who's recruited? What skill sets do you need? What training do you need to be able to play the role of working with folks where you're navigating personal, financial, health, and medical and the like?
So one of the great things is as students receive training, residents receive training. So as students receive trauma-informed training, we want to educate the residents as well. What is trauma? Have they experienced trauma? How to access care to that? Also motivational interviewing as well. How to get people to take ownership for their health, how to help people to see value. Before this type of training, residents was more accepting of diabetes. My mother had an amputation. This is just what happens. I'm losing my vision. It's because I'm growing older, versus recognizing the opportunities to have intervention, to have services, change lifestyles that can make an impact on that. And one of the projects that we're launching this semester is bringing in technology with the Alexa Echo Drive, which we're putting Echo Dot. We're putting in the apartments so that we can address social isolation, so we can address response time to falls as well. So we're putting accelerators in the cell phone, so if the phone hits the ground, Alexa asks, are you okay? Did you experience a fall? So all of this is being done at no cost to the residents as well. So connecting technology to their health.
Great. Clarke, you mentioned the prevalence of absentee landlords. When I was reading up about the work going on in Buffalo, I did read about a proactive role of engaging landlords, particularly in the lead abatement area, and I was struck given the often contentious relationship around what role landlords play. This seemed like a harnessing of their resources and initiative. I wonder if you could just say a little more about that.
Sure. So, again, I think in our community, not only are there a prevalence of landlords, but there's a prevalence of landlords who live in the community too, and they're often, owners of 1 to 4 family properties. They may be owner occupants. They may be on the cusp of poverty or work among the working poor. And so I think for that kind of landlord type, we've found some success in marketing and inviting them into participation in our Push Green program, which again provides access to no-cost energy assessments that New York State offers to low and moderate income residents and households, and kind of creates, in some cases, if tenants are income qualified and means tested, they can access free grant-based services. And I think for the landlord, at that point, it's really just getting them to sign off on the improvements that work can be done on property they own. And so, that said, I think split incentives remain just a tough nut to crack. And I think at a programmatic level, at just kind of the individual household level, and as I mentioned, to the extent most renters in Buffalo are responsible for their own utility bills and utility accounts, that just creates a real disincentive for landlords to make those kinds of investments or to even approve of work happening in their house for fear that maybe other conditions are uncovered that could imperil them with city inspectors or county health departments, things of that nature. So yeah, there's no silver bullet solution, but I think just kind of persistence in finding those landlords that want to do the right thing, and I think that we found those landlords to be out there.
Great. I have a big picture question here that is going to play out very different in each of your environments, but in the work I've done over quite a long time, we often talk about public-private partnerships, and it sort of rolls off the tongue, harness the resources of the public sector, harness the resources of the private sector, but making those work is really hard. And yet, when I listen to each of you, there is clearly an element of public-private. So I just wonder if each of you could reflect on some aspect of that. You don't need to reflect on all aspects, but sort of how did it come together? At what initiative? How do you figure out the relative roles of the public sector, the private sector? What is it that makes the glue stick long enough that you can see progress and move to the next problem? Again, I'm not expecting answers to all those questions. Just I'm so struck that none of the examples you each have explored and explained could have happened without that kind of relationship. And I'd like you to give some reality to the challenges and the successes. Don't need to go down the line, but whoever wants to take it.
I'm happy to jump in. Great. So we have had a try or two in the past at public-private partnerships that were less successful. What feels different and is different about this one is the fact that we are building it together. And it wasn't that an idea had been developed and then brought solely to the other party, i.e. hospitals, for solely funding. and that was it. No, this is engagement from all stakeholders sitting at the table, the city hospital presidents, the city, and Healthcare for the Homeless, the nonprofit, with a steering committee, probably similar to what you have in Roanoke, that will continue to modify and tweak the project and provide input. And honestly, that is what's making a difference. I will tell you another thing that I think is making a difference is engaging our frontline staff. I talk about this work at the hospital, at our town halls, at our management forums. The level of engagement of people who work at the hospital who are excited about this and are emailing me and calling me, I want to be a part. How can I do? Can I help renovate a house? Can I, it's really galvanizing to see that kind of engagement. So those are two key ingredients.
Great.
So for me, trying to replicate partnerships with university and housing, the question always comes up, well, who's going to pay for this? Who's going to pay for the professor's time to be supervising the students at your site? So it has to be an investment by the university to see value in training tomorrow's clinicians. Also, housing should contribute as well, because our residents are going to have improved quality of life. They're going to have better health. We're going to have less turnover as well. And we're also trying to get the insurance companies to come to the table so that they can see the benefit of this partnership as benefits to their bottom line as well. So we have a presence in a few cities, but as we try to expand it, the pushback tend to be who's going to compensate for the time of the professors. Particular that we use an interdisciplinary approach. So one resident will be seen by a psychology student, pharmacy student, and exercise science student. The other would be 3 different disciplines. So those disciplines are learning from each other, so they're not just working in silos. And then they do a debriefing with their professor as well. And this year we brought in the University of Richmond School of Law. And our thinking was power attorneys, living wills, and wills. And yet we've reaped the benefits of residents identifying their needs as well, which is paying student loans, having their Social Security income garnished because of student loans, being 70 years old and paying child support. So these are real matters that our School of Law has been able to tackle that would have likely led to eviction otherwise.
Yeah, thanks. So, I'll get back to the program I've been talking about. So, historically in New York State, the state energy agency, NYSERDA, is responsible for creating and administering various energy efficiency programs that are means tested to market rate. And so the kind of public-private partnership in play there has involved that state agency and private contractors in communities that they serve. I think the intervention that we advocated for in that campaign I mentioned, nearly 10 years ago, and I think we've had a track record of success, is been to kind of insert community-based organizations in the middle of that partnership to ensure that there's accountability and that benefits, as really determined by residents and the beneficiaries of those services and programs, that those benefits can be named and can be accounted for as contractors are deployed to do energy efficiency and healthy homes work. And so, we worked with the state agency and with contractors who were kind of amenable to partnering in this kind of triangular way to develop some localized community benefit standards and goals that involve local hiring, provision of living wages, kind of enhanced customer service, and kind of co-project managing a lot of these projects. So we would, train and certify our staff at our organization with the same credentials that contractor staff had. And then we would kind of deploy together into communities and offer our services to residents as kind of a check against maybe the profit motives of those businesses as they came in to scope out work and to recommend improvements.
I think in Roanoke, it's kind of a combination of we are a relatively small community, so we all see each other all the time. I'm on the steering committee for Bank On and United Way, and also the city manager and others will see. So I think it's just that we're always interacting with one another as one. The second is it is very much driven by the presence of nonprofits, including our healthcare system, which is though it employs 14,000 people across the entire system, are nonprofits. And I will say we have not had as much success with our for-profit hospital and getting them in as a part of the partnership. And really a lot of folks that just genuinely care about the work that's going on, whether they're in the nonprofit side of things, whether it's my council or whether it's the CEO at the hospital as well. And I think that has all kind of played well together with it. And we're a relatively resource poor community. There are no sizable foundations that everyone turns to. There really are, if we're going to do things, it's because all of us got together, pooled the limited resources we have to do those things. And I think all of that has really played into strengthening those relationships as we've gone along.
I have more questions, but you probably have some yourself, so I'm going to give you all a chance to join the conversation. Okay, so let's take the two folks right here in the front.
I'm Lottie Aaron. I'm a senior fellow at the Urban Institute, and I do have a quick question. But before I get to that, I also want to say that I am the co-director of the National Coordinating Center for Robert Wood Johnson's Policies for Action Research Program, and we have a call for proposals coming out in early 2020 to support research that's oriented towards policies, and it will be devoted explicitly to the intersection of housing and health. And we are very much wanting proposals from researchers that partner with community-based organizations. So please, through either yourselves that are researchers in the room or researchers that you know you want to partner with, look out for this, because we would love to continue to fund important work in this space. My question quickly has to do with to what extent have any of you found that any of the various community health needs assessments that are being done and are required of hospitals, public health agencies, and even school districts now, guiding what is happening in the communities, and how our community benefit dollars, which hospitals are required to spend as part of their tax-exempt status, being devoted to those priority health areas that community members themselves are identifying?
I can take a first shot at it. The community health assessments have been integral to what we've done and what has come as a result of that. The maybe three cycles of those ago was when, though everybody kind of knew anecdotally what was going on in the neighborhoods, it was in stark data when it said those two neighborhoods have life expectancies of 14 years less than the neighborhood down the street. At that point, the healthcare provider sort of drew a line and said that's unacceptable. We're not going to have that in the community. And so everybody quickly mobilized, and that became really the collective impact response. A backbone organization, which is led by the United Way, was established. We partnered with Robert Wood Johnson Foundation and many, many other providers to really all hands on to respond to that particular piece. Community, the charitable dollars coming out of the hospital have been essential as well. They fund almost every initiative we do in the community to a certain degree, whether it's one of our clinics or whether we have a mobile food operation where groups go out with a mobile market that actually deliver or make available healthy food. You pay for it, but they have a program where they'll actually underwrite kind of doubling SNAP benefits and those types of things. That all came about from that particular initiative and effort with it. The interesting thing that right now they're reluctant to talk a little bit about is we recently in Virginia, thankfully, expanded Medicaid. And so actually a lot of what they were relying on to meet those obligations are no longer there any longer. And so that has, for us, that has freed up resources. For them, it's kind of challenged them. How do they now repurpose those dollars? So those have been instrumental in Roanoke for us to be able to move those conversations forward.
As a hospital administrator, we very much use our community health needs assessment work, and it's been fun to see it evolve over the last several iterations. So 2 times ago, really 3 times ago, it was very much focused on chronic diseases. We heard from our community, and we took this very seriously. I mean, in-person interviews, going to churches, focus groups, surveys, questionnaires, and we heard it was typical chronic medical conditions, hypertension, diabetes, things like that. The last iteration, not the most recent, but 2 times ago, we heard the top three were behavioral health, jobs, and public safety. It was a complete turnaround. So the most recent, and that has helped us guide where we strategically target our community benefit dollars. And the most recent iteration we did in conjunction with Baltimore City and other city hospitals. We decided to undertake it all together instead of resurveying a lot of the same population. There's a lot of overlap, and we divided it into two parts. Tell us about what chronic medical conditions and what are more of the social determinant type conditions. And we got pretty much the same answer. So we use it very much so.
One of the things we got out of is identifying hotspots, who were the high utilizers, what zip code, and then narrow it down to our population. Mental health came out of that. Also, residents expressed a desire to have a cancer support group, whereas it doesn't just become a death sentence. So how do they deal with a loss of weight, body changes, access to medication, nutrition? They also express how do they share with people that they have cancer, and how will people respond to them as well. So, and also health literacy, that was critical in that as well, because understanding documentations that you receive from your provider and knowing what to do with it is critical, and being able to communicate to your provider when you don't understand.
Yes, next buddy.
Hi, good morning. My name is Regina Reed, and I am with the National Healthcare for the Homeless Council. My office is actually based out of Healthcare for the Homeless in Baltimore. That's involved in the waiver supportive housing project that Redonda spoke about. Thank you for highlighting that, and thank you to all the panelists for your perspective. My question is probably best suited for Greg. What you shared was really insightful at illustrating that there's a lot more challenges to escaping homelessness beyond just giving someone housing. You spoke about managing a budget around a cable bill, something that for those of us who have been housed our whole life seems simple but may not be if you've been experiencing homelessness. So to go with the theme of this panel, my question for you is what do you think is the number one challenge to sustaining housing beyond just providing affordable housing?
I think helping people find self-worth, find value in themselves. So give people something to strive for, to live for, to be able to set goals. In May, we just had a 71-year-old resident graduate with an associate's degree. So in the state of Virginia, you could take college classes for free over the age of 60. So setting a program where we're enrolling people in classes, we're providing tutoring, we're giving people something to strive for, help them achieve goals, I think is significant. And then not taking basic things for granted. So we do a shopping buddy program where if you have diabetes, we'll pair you with a nursing student to go shopping. If you have some mobility issues, we'll pair you with an occupational therapy student. If you have some financial literacy issues, money management, we'll pair you with an accountant student to go shopping. So we're partnering with the grocery stores, so to teach how to shop to the residents, to the students, and we're partnering with our computer lab to how do you download coupons, and then we connect that to the Alexa Echo Dot, to read out what's on sale, what's in need within the home, create a grocery list. So taking everyday basic life and kind of making it essential for residents, I think is key.
If I could respond too, so I think all of those things are super essential. And this ties into some work we're doing at PUSH on the organizing front is empowering tenants in this instance to kind of exercise greater control over their homes, their living environments, their buildings. So we're in the process right now in Buffalo of organizing a citywide tenants union to ensure that tenants know their rights, or have some kind of collective means of recourse at the building level and at the neighborhood level should they find that landlords aren't reinvesting in properties or are kind of being ruthless in various ways to displace tenants from units, especially when organizing of that kind begins to happen. And just quickly share an example in Rochester, an ally in a statewide coalition was at a party with tenants that he's been working with and organizing, and the party was in their building, and management called police and had him arrested on the site for trespassing because of really what's legally permissible of kind of organizing activity in that building. And so I think absent greater focus on and protections around tenants' rights to organize, I think we'll see a lot of steps back in terms of access to affordable housing and the preservation of those units over time.
I'm going to take one last question here in the center, and we'll wrap it up on time.
Hi, my name is Jacob Fisher. I'm with Penrose. We are an affordable housing multifamily developer based in Philadelphia. We have an office in Baltimore as well. The question is for Dr. Miller. I was wondering, are you at all tracking the savings to the system that is garnered from providing the stable housing to the homeless individuals?
Yes, we are tracking outcomes because we think if it shows what we think it's going to show, it's expandable. And we can go for another 200 slots and another 200 slots. So an outside firm, forgive me, Hilltop, has been hired. So it's not, me, it's not who's a neutral party, is looking at healthcare utilization, looking at treatment of medical conditions, looking at going back to work, looking at healthcare savings, cost, all of those outcomes are being tracked, yes, and it will inform our future work.
And we have a good relationship with Hilltop. Maybe they'll submit a paper to it.
Here we go.
This has been a really rich conversation, and I'm struck by a couple of things that I just want to bring up as we bring our morning to a close. It's so important to begin with the evidence and the understanding, but it's also so important to transition to what's happening. And these words and themes and phrases kept coming up: interdisciplinary, relational, empowerment, conversation, authenticity. We are not going to break through on these kinds of issues if we don't break through on how we interact, how we handle legacies and current existence of racism, of disempowerment, of power relationships. These are not separate topics. It's impossible to have this conversation without bringing them in. And the data and evidence can tell us a lot, but the movement on them requires language and interactions that are much deeper than the data can get to. So I will just say that at Health Affairs, we're really proud to be able to be a forum for both the high-quality empirical work that was presented in the first session, the exploration of what we know, what we don't know, and the building of an evidence base and a business case, which is necessary for the sustainable investments that were discussed. But we're also happy to bring together with that evidence the lived experience, the practical efforts being tried on the ground, and the candor with respect to trying and not necessarily knowing what will work, but being open to continuing to build the evidence base so that the next participant in these efforts can do it better, can figure out what elements are successful, which are not, and we can just continue to improve. So with great thanks to the Robert Johnson Foundation for funding the series and for this event. You heard reference to them also supporting various elements of the work being done in this domain. Many thanks to you all for joining us in person and many others. I got a few emails from people watching on live video, and it will be archived as well. Please also then join me in thanking our final panelists as we bring our morning to a close.